It's a great pleasure for me to introduce Professor Scott Bell. Scott's a fellow of our academy. He is currently the chair of research at the Gold Coast Health and at Griffith University. He's driven all the way up from across the border today to get here bright and early on a Saturday, so I'm very grateful. He's a senior respiratory physician, so he has a long background in treating patients. He has a big interest in adult cystic fibrosis and was previously executive director of research at Metro North over here. And he was also chief executive of the Translational Research Institute, TRI, across at the PA Hospital campus across the river. So Scott has an incredible pedigree of medical research, also as a clinical leader himself, as a practicing clinician, and as a clinical leading academic and administrator. So Scott has seen it from all sides. So Scott, it's a great pleasure to welcome you to the podium for your talk. And if I can get the slides to work, which I have, you're ready to go. Over to you.
Thank you, David, and welcome everyone. It's a great privilege to be here today and give you some insights to the bumpy career that I've had in medical science and clinical science. These are my disclosures, and perhaps the most relevant today is to highlight that I will be showing some of the patients that we've looked after over the years in the presentation, and those patients have provided approval for the use of their photos in these sorts of presentations. So we will often hear these two statements that why is it important that research be a critical part of healthcare? And the two statements that you will often hear are that research-infused health services deliver better patient outcomes. And how does it do that? It does that by improving mortality, patient outcomes, and patient satisfaction, and also helps support the better performance of our healthcare system. And secondly, research-infused health services support attraction and retention of highly skilled and a diverse workforce. And that's particularly important over the course of the next two decades, because we are going to have and continue to have acute shortages across the multidisciplinary team. But perhaps more importantly, despite saying these things all of the time, these statements are actually underpinned by important research, and I just wanted to highlight that these are some of the recent studies over the past 15 years that support those two statements. So as David alluded to, most of my clinical care has involved delivery of coalface care to adults with cystic fibrosis. And the journey of cystic fibrosis care over the past 70 years has really been transformational. Since the original description of the disease by Dorothy Anderson in the 1930s, where at that time the condition was uniformly fatal in young babies born of this disease, to now almost normal life expectancy. When I started my career in cystic fibrosis, which was in the early 1990s, most research was single-centre observational cohort studies. And through that first decade or two, we saw the advent of multi-centre, multinational, randomised control trials on scale. Those therapies which you'll see listed here, including inhaled antibiotics, mucolytic agents to help move thick, tenacious sputum, anti-inflammatory therapies, and hydrating airway therapies, all impacted on downstream consequences of this monogene disorder. And in the latter part of my career, what we've seen now is the move into personalised or precision medicine. And this has further improved not only the length of life, but also the quality of life of our patients. So looking back to the early stages of my career, I wasn't an early adopter as a medical student. I didn't really think research was going to be part of my career. It was during my specialist training as a respiratory physician that I had two tremendous mentors, Peter Piggott and Norbert Brend. Peter was one of the best clinicians, probably the best clinician I've ever worked with. Norbert Brend was a clinician scientist, and this was in Sydney. And I was lucky enough to work with both of them and some other outstanding clinicians and clinician scientists. And it was Norbert who said, here, have a study to work on during the latter part of my advanced training. And clearly one of the major challenges at that stage is juggling the sort of training requirements, the delivery of patient care, and also trying to find time to actually work on a study. And it was those initial sparks that gave me an opportunity to then pursue a career to start my research training. And where do you do that? Well, that was partly influenced by family requirements to go back to the UK. And we were about to ship, as you did in those days, some boxes, which was our goods and chattels, to set up a house in Nottingham and to actually do a research higher degree in intensive care medicine on acute respiratory distress syndrome. When my supervisor sent me a letter, as you did in those days, to say, actually, I'm moving to Cardiff, and if you want to come to Cardiff, you can, but you'll be working on cystic fibrosis. So it's really quite extraordinary, and I think one of my key messages here is don't expect that your career will be linear. There will be ups and downs, and embrace opportunities when they come and take some risks. And of course, then I arrived in Cardiff and there was absolutely nothing to do research with, plenty of patients to do research on, but no equipment. And that was certainly one of the challenges in the first year or two. So my wife and 15-month-old son flew to the UK, where we moved to Southeast Wales, to Cardiff. That was 3 years after the discovery of the cystic fibrosis gene, and there were 3 seminal papers published in Science on the 5th of September 1989. And as you'll see, that has really been very influential. That discovery, which I had absolutely nothing to do with, has been so impactful on the careers of many people working in this field. During my first year, there were 3 important events that happened. Firstly, I saw David Campese score the winning try at the Old Arms Park in Cardiff against Wales, and that was really important, although I wasn't so popular when I returned to work on Monday. Secondly, I saw Mark Taylor score a ton in the second test at the Ashes test in that year. And that was really important, especially as my consultant was a member and actually invited me to go, and he really left that day with his tail between his legs. And thirdly was attending my first cystic fibrosis conference, which was a world conference held in Dublin. And one of the co-discoverers of the CF gene, a very famous scientist, and you'll know this name because he's gone on to do even more important work, was Francis Collins. You know, he was the lead of the Human Genome Project, and then went on until very recently to lead the the NIH. And he was giving a plenary. And picture this. This was my first international conference, and the plenary speaker, who was a co-discoverer of the CF gene, walks onto the stage with a guitar. And actually, he sang a song at the start of his talk about the discovery of the CF gene. And it was really firstly moving, but secondly, incredibly impactful for the several thousand people in the audience, including this very early career researcher. He went to do that again at another conference which I attended at the 21st celebration of the discovery of the gene. And not many people in the audience had seen the first talk and song, but at least they knew what was coming. So in the 1990s, the average or median survival for people with cystic fibrosis was early 30s, and many children still died before they achieved adulthood. Similarly, more than 2/3 of the CF population were children, and only 1/3 were adults. And as I highlighted previously, we saw in the 1990s the emergence of large-scale clinical trials. Here are two examples. Firstly, a mucolytic, recombinant human Dornase alpha, and secondly, another study which looked at month-on administration of inhaled tobramycin. The increase in the CF population, particularly in adults, that started to occur in the 1990s, resulted in a density of patients attending healthcare facilities. And we saw for the first time the potential for cross-infection between different patients with cystic fibrosis. And this particular organism, now known as Burkholderia cenocepacia, did appear to be associated with social contact between people with cystic fibrosis. And importantly, but also sadly for the CF population, that meant segregation of patients, including the disbandment of holiday camps, which were a really important social connection for people with cystic fibrosis. As I highlighted previously, my research was done in an era, my early research was done in an era where we did do single-centre studies, and we were able to publish in quite significant specialist journals papers based on 22 or 100 patients. And things have changed. This paper is to highlight that and also highlight how far we've come. And the perhaps most important thing here is to highlight the proportion of patients who were 35 and above, so older adults, was almost negligible. So after finishing my research higher degree, it was time to get a real job. And I was lucky enough to be employed as a respiratory physician at the Prince Charles Hospital, where I worked until December of last year for 28 years. In the early stages at Prince Charles, we did not have an emergency department, we had an emergency room. And I was lucky enough to work with these 4 amazing clinicians: cardiologists, intensivists, respiratory physicians, and medical imaging experts. And they really supported the early stages of my career as a consultant physician. When I started, we performed the first lung transplants in Queensland. And with Andrew Galbraith, bottom right, who sadly passed at the end of last year, we did a 1 in 2 roster, and I was the lowest paid cardiologist in Australia as a respiratory physician supporting the heart and lung transplant program. We were lucky enough, working with our consumer group, to successfully get statewide status and funding to establish a multidisciplinary team in cystic fibrosis. So moving into the 2000s, we started to see a steady increase in the median survival, so that patients were often living well beyond those handful of patients that I cared for in my early years, beyond 35 years of age. And by the end of the 2000s, we saw for the first time in most parts of the world where 50% of the CF population were adults. And we also saw after some significant drug discovery work, the development of potential gene-modifying therapies for the first time. And at the end of the 2000s, a phase 2 study of this chemical, now known as ivacaftor, but VX770, developed initially by a startup company, then moving into a pharmaceutical company called Vertex. The first proof of principle that you may be able to impact on the basic defect of this condition. You'd seen all of these new therapies, mucolytics, anti-inflammatories, and antibiotics. It was very clear that those therapies had a burden of care, and it wasn't entirely clear how much quantity of life was being matched by improvements in quality of life. So during the 2000s, there was the development of really tools to help understand better both the quality of life and also the burden of care, which was not insignificant, with huge numbers of therapies needing to be taken day in, day out, no matter what life events were happening. We were able to develop a large multidisciplinary care team and start to work with regional clinicians. This is the bottom left photograph is a historical photograph of one of my colleagues that I've worked with for the last 3 decades, and I don't think it is at all hard to work out which one was the visiting doctor compared to those people working in Townsville. We also saw significant changes in the models of care, with patients being able to deliver their own care at home and also start to have families as quantity of life started to improve. And we were also able to participate in the early phase 3 studies of these potentially disease-modifying therapies. Moving into the 2010s, we saw a significant and progressive improvement in length of life. And we also saw a greater number of adults attending relatively new CF centres around the world. The healthcare system may actually train up people in new specialties where patient cohorts are growing rapidly, such as in adult cystic fibrosis. But what it doesn't change very rapidly is the physical dimensions of the healthcare system and how our hospital and many other adult CF centre-based hospitals around the world really struggle with how to care for this very rapidly growing group of patients. As you do, I took up the opportunity of taking on some clinical leadership roles, and with that we were able to establish some firsts. We appointed the first cystic fibrosis pharmacist nationally, and the first training position in adult cystic fibrosis care. And we also gradually built the skill set of our multidisciplinary team to be involved in research across the continuum of care for our patients. Our research continued to pose questions that often when I got the answers to those questions, I'd really wondered why we'd actually started to ask those questions. We identified that some of the common CF pathogens, particularly Pseudomonas aeruginosa, were often shared between patients, probably due to close proximity in an increasingly tight environment with a huge number of new patients transitioning from paediatric to adult care. Of course, the dogma at that time is aerosols don't carry pathogens, and that it's droplets, so our patients can mix quite comfortably as long as they stay more than a metre apart. And our work really started to question whether the link between cross-infection might be due to aerosols associated with coughing and just breathing and communicating between patients. Our mask work changed policy and practice globally by demonstrating in the pre-2020 era that masks reduced the outward movement of potentially infectious aerosols containing bacteria and other potential pathogens. And our multidisciplinary team was awarded a Eureka Award in 2018. So moving into the 2010s, Phase 3 multi-centre international studies looking at various combinations of CFTR modulator therapies were embraced and undertaken, including in centres within Queensland. 2 of these papers are published by Australian CF clinician scientists, including Claire Wainwright, based in Queensland at the Queensland Children's Hospital. So as you do, as you go on life journeys, you have mentors. And of course, mentors are supposed to help guide you in making the right decisions. And when approached about taking on a role as chief editor of the Journal of Cystic Fibrosis, several of my mentors said, "You are absolutely crazy. Don't do it, it'll destroy your career." And sure, this 6.5 journey as the chief editor of the Journal of Cystic Fibrosis probably didn't enhance my understanding of science. It certainly enhanced my understanding of human behaviour. So what about our research? We've continued to study the potential transmission and acquisition pathways of infection, both between patients but also from the natural environment. We've looked at ways in which patients might actually spread infection. And just as we've heard lots talked about over the past 5 years, there are likely to be super spreaders in our patient cohort, and masks are highly effective in reducing the potential of risk of infection. Our current program of research really looks at certain parts of the environment and how CF and other chronic respiratory diseases may actually be exposed to particular pathogens within the environment, including drinking water. So moving into the 2020s, we've seen a huge increase in the median survival and a continued increase, so that we've reversed the 2/3 of children are now 2/3 of our CF population globally are adults. The left-hand panel of this slide demonstrates that the natural history, the rate of decline in lung function, is normalised in people taking triple combination CFTR modulator therapies. But importantly, we need to recognise that probably 50% of the global population do not have access to these life-changing therapies. They are hugely expensive, more than $250,000 Australian dollars per patient per year. Some would say outrageously expensive, and many patients do not access these therapies. So when speaking to my mentors subsequently, when offered an opportunity to lead a global blueprint for cystic fibrosis over the next 3 decades, again I was told this would destroy one's career and be crazy. It certainly destroyed my family life for a year or two as Felix Ratchen and I tried to harness this group of 38 scientists. Lancet gave us 25,000 words. We divided that into 5 sections of 5,000 words. The first section came in 2 weeks before the deadline at 30,000 words. We realised very quickly we had a problem. I looked after the editing, Felix looked after the endnote, and somehow he managed to get the 530 references into the EndNote library without destroying his computer. So perhaps to summarise, I'd like to highlight that one needs to take opportunities. I worked in a location where there was negligible research going on and there were no on-site laboratories. You will need to seek and find both the expertise and the technologies. As a clinician, it's hugely exciting working with scientists like Dennis Moss and Rajiv Khanna. But it does take work and energy to build and maintain those collaborations and a lot of communication. And also you need to somehow balance your work life, home life, and occasionally see some patients. I'd encourage you to embrace enthusiasm and colleagues such as research scientists, in my case, infection research programs, aerosol teams, and of course, the skills of our multidisciplinary team. Consumer and community involvement is crucial. This young woman, Sarah, caught this barramundi in North Queensland. Before starting on CFTR modulators, she was looking down the barrel of a transplant, and she's now living her best life. And I can't underestimate the importance in building your relationships with the multidisciplinary team early as you can in your career. Thank you very much.
Scott, that was absolutely inspiring and a terrific summary of a long and rich career with lots of highs, I can see. And you didn't tell us about any lows, but I'm sure along the way there are some lows. We have time for some questions, people. So please, if you have any questions for Scott Bell, please throw them this way. While you're gathering your thoughts though, Scott, you drew attention to a number of different strands of research through your career. So you've done sort of physiological studies involving measurements of people's breathing and things like this. You've done antimicrobial stuff. You talked very strongly about the quality of life stuff. So where did you pick up all these different skills to be able to do so many different strands of research and still be a clinician at the same time?
One might argue that I wasn't very good at any of them, and that's why I had to keep moving on from one to the next. When you work in a healthcare system, or at least for me, I was pretty busy seeing patients, so I didn't have a lot of time to actually develop a research program. So in my early years, I was lucky enough to link up with a number of really internationally regarded scientists and clinician scientists. I mentioned Dennis Moss at QRMR, Rajiv Khanna, and then Peter Sly and Keith Grimwood at the Children's Hospital really helped. And then I was lucky enough to work at the same start, roughly in the same era as Claire Wainwright, and she's a paediatrician involved in cystic fibrosis care, and we've developed a sort of too-many-decade collaboration of working end-to-end, both clinically and research. So we had questions in the clinic and took the opportunity of finding the best scientists locally and nationally and internationally and worked with them.
So collaboration.
They actually did the hard work, really.
Okay.
We provided the question, some clinical information. We were heavily involved in that collaboration, but the science had to be done by other people because we didn't have those skills. And eventually we were able to develop our own microbiology laboratory, and we were on a roll then.
Yeah, fantastic. Questions? Kirash, yes, Professor Kirash Khosrow-Tehrani, one of our panelists later on.
Yeah, I just wanted you to maybe reflect on the opportunities for research for the clinicians, then and over the years until now, and in your role at TRI as TRI CEO.
Yeah, there's countless opportunities, but I see only a relatively few clinicians that embrace those opportunities. between Princess Alexandra Hospital and the TRI, where there are 1,100 amazing scientists, is one small road. Most of the clinicians walk over that road to buy coffee because it's better than Starbucks. But the best of those future scientists stop and talk and embrace. It is challenging because, you know, as full-time clinicians, we don't have much time, and there are lots of commitments and constant pulls on your time. And the reality, even in the current generation, is this is not just a 9-to-5 job. One has to extend oneself. And similarly to the scientists, it's important to recognise that clinicians can't do meetings between 9 and 2, which suits the scientists but doesn't suit the clinicians. So scientists have to make a bit of an effort as well, it's not just the clinicians, in extending their workday, finding novel ways of making those links. And I think it is important for the clinician to make those steps, but also important for the scientists to get out of their offices and their labs and actually find the clinicians. What you often hear is scientists saying, I've got this new thing, have you got a use for it? And I think much more importantly is the scientist to sit down with the clinicians and find out what are the clinically important issues, and maybe I can think of a thing that is relevant to that.
Is there a question here? There's one over here. Perfect. Christos, yes. Wait a minute, wait for the mic. Here we go.
Sure. Yeah, so you mentioned that you've been lucky to do something, and then I was just wondering how much of luck do you think actually contributes to your career, and how do you get through or fight when there's bad luck? Thank you.
So I think I've needed a lot of luck compared to a real scientist like on my right, who's got talent. Look, I think it's there's drive, there's luck, and there's taking a risk, I think, and you need a mix of all of those things. It's not just luck, but you've got to have a bit of drive, and you've also got to sometimes go, well, I'm not sure how this is going to go, but let's give it a go.
Yeah, and I'd agree. And I think part of it is you could call it luck, or you could just call it the opportunities that life throws at you. And sometimes you have to, as you said, take a risk or take a punt. And then if it works, it's good luck. If it doesn't work, it's bad luck. But I think the message you'll probably get today from a few people is life always turns out quite differently to how you planned it. There are twists and turns along the way, and we're here now standing and looking back. You're at the front making those decisions. But with the right mindset, you can turn most of those things into opportunities. So anyway, Scott, we could talk all day, but I have other speakers who I want to bring up. So thank you. Please join with me, and thank you, Scott.